Tracheoesophageal fistula. PF. A tracheoesophageal fistula, TEF, is an abnormal connection fistula between the trachea, windpipe, and the esophagus, food pipe. This congenital or acquired condition can lead to severe complications due to the mixing of air and food pathways. Here's a detailed overview. Types of TEF. 1. Congenital occurs due to incomplete separation of the esophagus and trachea during embryonic development, often associated with esophageal atresia, EA, where the esophagus ends in a blind pouch rather than connecting to the stomach. Classified into 5 types based on the anatomy. Type C, most common, the upper esophagus ends in a blind pouch, and the lower esophagus connects to the trachea via fistula. Type A, pure esophageal atresia without a fistula. Type B, the upper esophagus has a fistula to the trachea. The lower esophagus ends in a blind pouch. Type D, both segments of the esophagus connect to the trachea. Type E, H type, a fistula exists between an intact esophagus and trachea without atresia. 2. Acquired TF, usually caused by trauma, malignancy, prolonged intubation, infections, or surgical complications. Pathophysiology. In TEF, swallowed food or liquid can enter the airway, leading to aspiration, recurrent pneumonia, or chronic respiratory problems. Air can pass from the trachea into the esophagus, causing gastric distension. Clinical features. Congenital TEF usually presents shortly after birth, difficulty feeding and choking during feeding, coughing or cyanosis, bluish discoloration during feeds, excessive drooling due to inability to swallow saliva, recurrent respiratory infections, distended abdomen due to air entering the stomach. Acquired TEF, chronic cough, hemoptysis, coughing up blood, recurrent chest infections, dysphagia, difficulty swallowing, aspiration pneumonia. Diagnosis. 1. Prenatal diagnosis, congenital TEF, polyhydramnios, excessive amniotic fluid may suggest esophageal atresia. Ultrasound or MRI may show a distended proximal esophagus, pouch sign. 2. Postnatal and acquired TEF diagnosis, contrast esophagography, demonstrates fistula or esophageal atresia. Bronchoscopy and endoscopy, visualize the fistula and assess the airway or esophagus directly. Chest X-ray shows air in the stomach or signs of aspiration pneumonia. CT scan provides detailed imaging of the fistula and surrounding structures. Management. 1. Immediate care. Prevent aspiration by keeping the baby upright and avoiding oral feeds. Use nasogastric or gastrostomy feeding for nutrition. Suction to remove secretions from the blind ending esophagus. 2. Surgical repair. Surgery is the definitive treatment for TEF. Congenital TEF, primary repair involves closing the fistula and reconnecting the esophagus to the stomach. Acquired TEF, surgery involves repairing the fistula, often requiring reconstruction of the trachea or esophagus. 3. Postoperative care. Monitor for complications like anastomotic leaks, strictures, or recurrent fistulas. Nutritional support and gradual reintroduction of oral feeding. Complications. Immediate complications, aspiration pneumonia, gastric distension, respiratory distress. Postoperative complications, strictures, narrowing of the esophagus, gastroesophageal reflux disease, GERD, recurrent fistula formation. Prognosis. With timely diagnosis and surgical intervention, most infants with congenital TF can survive and lead normal lives. Acquired TF's outcome depends on the underlying cause and associated complications. Multidisciplinary care involving pediatric surgeons, neonatologists, and respiratory specialists is essential for optimal management of TEF.